I'll try to keep it brief, as the top. There's nothing. I mean, it's an important topic because, but unfortunately, we don't get many of these small cell lung cancers. As you see, just a second. Yeah. Okay. So it constitutes about 15% of all lung cancers, and we know that the biology is completely different from non-small cell. That is why we are debating why we should do surgery even in early stage. And unfortunately, as I said, only 3% of small cell actually present early, unlike the non-small cell. And is there a role? Why are we even talking about role of surgery? Is yes, sometimes because we know that about 30 to 50% of the small cell lung cancer following a concurrent chemoradiotherapy does have local recurrence and occasionally can be managed by surgery at that point of time. But actually, what are the indications? I see probably the only indication is the T1, T2, and when I say T2, up to only 5 centimeters, and N0, M0. Surgery alone is never adequate, unlike non-small cell cancer, where surgery alone in early stage could be one of the best modalities for cure. As seen in the British MRC and the MSKCC, which comes from the database, surgery alone, very dismal outcomes with a 5-year survival rates of around just 1%. So how do we select a patient among this T1, T2? These patients should be extensively evaluated for nodal and metastatic disease, and we have to ensure that they are N0 and also M0 by PET CT, MRI, and invasive mediastinoscopy if necessary after and over and above an endobronchial ultrasound to ensure that we are dealing with an N0 disease and not an N1 disease, where surgery may be futile if patient turns out to be N1. Oh. So there are a lot of studies. Most of them have been retrospective, as you see, or prospective study designs with very small numbers. As I said, the numbers are small because the incidence of these operable ones itself is about 3%.
Can I?
And I think one.
I'm in a webinar.
Okay. So the most of these are retrospective study designs, and the 5-year survival rate is sometimes impressive among those patients who have undergone surgery in the prospective as well as the retrospective studies. There's one randomized controlled trial which we see. This is post-induction chemotherapy. Is there a role of surgery? This had both early as well as advanced tumors. There was no survival difference among these patients. So how do we say that there is a role of surgery? Is mainly only because of the prospective and retrospective. And I don't think conducting a randomized controlled trial is going to be challenging, keeping the numbers as the numbers are slightly on the lower side. So surgery should always be a part of multimodality treatment. And what is the evidence we have? We have 2 propensity matched analysis studies which show that they could benefit, stage 1 patients could benefit with surgery and as a part of multimodality, but never surgery alone, as I've already mentioned. So this is a study from Vekiam et al., where about 29,000 odd patients and 2,089 matched small cell lung cancers who had undergone surgery. Among those, if you see, the stage 1 patients definitely had a better overall survival than compared to those who did not undergo surgery. This was not, however, though the p-value is statistically significant, but this significance is not much seen in stage 2. So, and it also said that those patients who have received adjuvant chemotherapy, so these were about, all those patients who have received adjuvant chemotherapy was about 500 odd patients in this 2000. And they said lobectomy with adjuvant chemotherapy was associated with significant longer survival. And as you can clearly see, the median overall survival is almost close to double when surgery was not offered. So surgical resection is associated with significantly longer survivals. And another propensity matched analysis, I think probably these are the only 2 trials wherein we could bang on and say that, surgery definitely has some role in small cell lung cancer. So the second propensity match, which included about 863 patients, which showed that surgery was associated with an improved 5-year overall survival, where it jumped from 16.8 to 36.7%, and lung cancer specific survival was also much better. And interestingly, they found that even in N1, N2 patients, the survival benefits were significant in almost all groups. But however, when the tumor size was more than 5 centimeters or an advanced T stage, there was absolutely no benefit in surgery. So these are some of the databases from where surgery versus no surgery for small cell lung cancer. And as you see, the 5-year survival, some of them have reported and makes So as you see, the survivals are slightly better when compared to having no surgery. And most of these had early stage small cell lung cancers. As I said, surgery after induction, no survival advantage compared to concurrent chemoradiotherapy. But however, interestingly, few observational studies have shown an excellent 5-year and 10-year overall survival ranging between 29 and 23%, which is probably not the case even with definitive concurrent chemoradiotherapy. NCCN also recommends in a patient with stage 1 to 2A, those patients who are pathologically mediastinal negative, lobectomy and mediastinal lymph node dissection or sampling is preferred and followed by systemic therapy depending on the nodal staging. So to summarize, surgery for small cell is indicated only in T1, T2, N0. Mediastinum should be staged adequately prior to surgery. Adjuvant chemotherapy is mandatory unlike the non-small cell and improves outcomes significantly. For PN2, adjuvant radiotherapy is mandatory and PN1 role is controversial. Thank you.